Any? Yes?
The biggest one is the term population health.
Yes.
Okay.
That would be a good starting point.
So population health, what does it mean? And who thinks it means what? You have an example of where that's been a difference? Yeah?
I went to a young physician went to a continuing education, and the CME defined population health as taking care of life animal patients. Very different than a public health or other orientation would be.
Okay. So it's population in one narrow sense of that particular network, but not population in the broader community sense that we would think of. Other example, is that a hand up or just, no, somebody's moving there. Okay, yeah. And then go to you.
We need to use the mic. The mic is too people on the web.
Okay. Do we have a mic we can carry? No?
Oh, I was gonna say. One of the things you learn in this business is sharing.
Collaboration. And
What's vague about that?
well, the experience was working with a number of hospitals and getting some feedback and hearing that the word collaboration suggested somebody reaching into my pocket trying to pull out some money. And then we explored the word alignment. Alignment seemed to be much more palatable, where it was a similar concept, but it required just changing language and understanding that collaboration wasn't necessarily the right word.
Okay, thanks. I know you have to go to the microphone. While you do, just to comment on that, it's also clear from the literature that collaboration has to be perceived as in the self-interest of the participants. And one of the things you're bringing up is that when some people heard it, they were thinking invasion of turf, invasion of resources, and there will be some of that. It does require a different mode of operation. But what's important is for everybody to understand that what will happen in the aggregate as a result of their joint efforts is a benefit to them, and they can see that the cost is worth the risk. One element of that. But you have an example.
My name's Margaret Reed. I'm from the Boston Public Health Commission, and we've been recently starting to work with some low-wage workers' unions and organizations around living wages, around access to housing, around safety at work. And, you know, workers' organizations are population health organizations. They're about the health and welfare of groups of people. But we talk about populations, and they have no idea. We talk about social determinants of health. That's what they do. They are all about improving the health and safety of vulnerable people, but we have this language that is just like a wall. So that's my example.
If I could follow, that brings up a point you made, but a second point is as we change our language, others find they can join in because the language is no longer separating it, and they say, wait, in fact, the unions are a great example. We have common goals here, and let's see if there are ways we can work together.
Yeah. And remember, as you work with other systems, which is so critically important in addressing social determinants of health, there are deeply ingrained terms that apply to the same unit, the same type of person, same type of organization, but are very different. So if I'm sitting down with a social worker, with a healthcare professional, and with a school teacher, one will use the word, that's my client, another will say, that's my patient, and another one will say, that's my student. And all of their literature and all of their documents use those terms, even though they're referring to exactly the same person or persons in that. Well, let me ask Lloyd, as long as we've heard a little bit about some of the difficulties here, even coming up with respect to the definition of collaboration. What would you see are the 1, 2, or 3 major pros of doing collaboration, and what would you see as 1, 2, or 3 of the cons, the disadvantages, the advantages, the disadvantages, the costs, the benefits?
The pros, and by the way, I often start meetings with new groups about this, is that very few of us went to school in medicine or public health or social work, wherever, actually to make a lot of money. Usually we didn't want to have chosen that. But we actually went because of a desire to help others and a sense of being part of something larger than ourselves. You can lose that along the way. And one of the things that I found really striking as a pro is that it brings people back to their roots. When you say, look, let's talk about how we can work together more effectively as a team than we can separately, because separately isn't working that well. You can tap into deeply held values that folks had not lost, but perhaps lost sight of. So hospital CEOs were religion majors and lived in inner city neighborhoods because they wanted to help and have been worrying about the bottom line. Start become colleagues and friends because you've overcome that initial barrier. So one of the big pros is it brings you together. And it brings you together as groups, and it brings you together with your community and members of that. A second one is actually related. I'm a family doc, and I'm used to seeing lots of folks in the office like every other family doc is. You know, you get to a point after a few years where you wonder, you know, at some point couldn't we do better? It's just a sense of I'm going to do my whole career, my whole life doing this, and I will make a difference to the people I touch, but all the people I didn't, I won't have dealt with. So there's a sense of actually being more effective in touching the things that really matter to oneself again. It's a variation of the first, but in this case it's very personal. The third is it works. I mean, it's actually fun. Now, let me pause on that word, because we tend to be pretty diligent, hardworking, and we measure our success by how much sweat we put into it. And there's a sense of we have to persevere in order to succeed. This actually is a frame shift, because actually you have others to help you, not necessarily people that you trained with, and they actually start helping take the load off. And you have to be willing to let go. And when you do get let go, it is a relief. And that sense of fun, I shared quite intentionally because there's a sense of joy, of a sense of we can do this, and a sense of being part of something larger than oneself that is incredibly motivating. Otherwise, we wouldn't be here.
Okay, I hate to destroy the mood, but what about the cons, the negatives?
The con is, and now we did talk ahead of time that this would be speaking truth to power. We have to let go of the sense of always being at the bottom. Primary care and public health are used to being the last, the lowest, the group that has to be suspicious about the thing that's handed, what's the hook. Don't lose that. On the other hand, one of the things we've realized is that sense of marginalization actually keeps us sometimes from partnering with each other because we're worried what each is trying to take from the other. In fact, the word that gets in the most way in the work we've done nationally is integration. Because we discovered in each group it's absolutely is convinced that integration means that with the little bit of money they have goes to the other party. And by the way, it's equal both ways. If any you think it's just one way. So it's actually being willing to let go of that sense of being marginalized and being comfortable with actually having the attention and living up to it. And you see some beautiful examples of that. So bizarrely, that's actually one of the hardest is the culture of actually being successful and actually being not successful in your own practice and patients, but being successful on a larger stage. And I think that's actually hard for us and it actually takes work. I think the other one is actually learning about data and for the primary care groups because we don't get trained in that and learning about teamwork. We actually do teams well in our office. We don't have a lot of experience in teams outside. It takes work and it does take courage. And we all vary in that depending on the day, but going in to tell your hospital CEO that the way he's delivering care is not effective. Or dealing with governors who don't want to say things, you have to find the language, but I think part of the con is that sense of not only am I going to fail, but I actually could fail spectacularly. I mean, I could be out of my job tomorrow, and then you have to be able to deal with that and parse it appropriately.
Okay.
That was a long answer, sorry.
Okay, and I may add to, I want to add something too, but again, I guess I'd throw it back to the audience. Anybody? The audience is already at the microphone. You're going to talk about a pro, a con, one of each?
Yeah, perhaps.
Or something totally different.
So George Isham, again, co-chair of the roundtable. So thinking about this in terms of my introductory comments, I looked at Wikipedia, and it's deep cooperation around a common or identical objective. And so based on a lot of the collaboration we've done, at least in Minnesota over a couple of decades, it seems like it's a tool in a tool set, not like the answer. So there are things that are much better when you can do them yourself. Mm-hmm. There are things that you should cooperate with each other on. There are things that you should collaborate or partner with. And there are things you ought to collaborate with. I think they each have a defined set of meetings, and I'm not so sure I could, off the top of my head, define them. So then the pros and cons in that context, would be the way I'd start thinking about it. Because what you give up when you collaborate is maximizing your own outcome as an individual player, whether you're organizational or an individual, whether you're within an organization or between organizations. What you gain is the power of working with others and other skill sets. In particular, if the nature of the objective is such that you can't achieve it alone, either as an organization or as a individual. So I think that you have to think about collaboration in terms of what you're trying to achieve together, and then you have to think about the pros and cons with respect to that. In population health, it demands, in my opinion, and I think a lot of us might agree, that multiple sectors work together. So we're trying to figure that out. And so, and then, and so therefore, we keep, coming back and taking another whack at, well, what's the common approach? And then what do people bring to the party? And then what are the barriers? The cultural, the expertise, the lack of communication, back to people don't work with each other. And so forth.
I'm
So
glad
those are
that you
some
brought
comments.
that up because for a couple reasons. One, when I said I was going to add something to Lloyd's comments, it was specifically to emphasize recognizing collaboration as a tool, not an end in and of itself. And there have been major problems caused by some foundations, for example, who have just required collaboration as a prerequisite for obtaining a grant. In many cases, collaboration was the appropriate tool, but in many cases, it was not. It sometimes brought agencies together, but then they didn't really know what to do. The culture hadn't developed that they could collaborate. The technology wasn't there for them to collaborate. And it really was not a wise decision or mandate. And I think your point of seeing collaboration as a tool to be used when it's necessary and not to be used when it's not necessary is very wise. Second thing that I saw in your comments, one of the factors that comes out of the literature has to, there's a couple, you want collaboration to serve the self-interest of everyone. One of the things that comes out of the literature is that a collaboration that should have some unique purpose that none of the members have as their sole purpose. Because otherwise that initiative can be seen as too threatening to that individual member. Now it may be that maybe that member shouldn't exist and should be superseded by the collaborative initiative. That's a possibility. But assuming that all the members have some legitimacy, people should be able to see how participating in the collaboration meets their self-interest, meets the community interest, and yet is not totally subsuming everything that they do if it's going to be successful. But Lloyd, you wanted to add something.
Actually, I want to push back a little bit. I actually agree on one level, but a story. When we started doing the work in Durham, we did a lot of work early, 20 years ago, around hypertension and diabetes. We could get a little bit of participation from our community partners. But it wasn't until we brought in somebody who really knew what she was doing, not me, who said, let's get together, break bread, and find out what the community really wants. And when we did, they said, Dr. Missioner, you're really nice and we value you, but this is about dental pain. I went, dental pain? And they said the major reason why kids miss school in Durham is because their teeth hurt. I didn't know that. So they said, well, if you want to help us, then you need to come to where we are, and the collaboration is going to be around our priorities first. And so let's work on a solution for that. And we did a dental van with them and with the schools, and it runs to this day, 20 years later. But my point is that collaborations also involve relationships, and they involve trust. And in this case, that was a question of whether the institution would listen to the community and could be trusted to put the community's needs first. And we did. I don't think we would have had any further discussions if we hadn't.
Yeah. If there are others who want to talk about pros and cons of collaboration, using collaboration as a tool, feel free to walk up, and to give you time to walk up to the microphone, I just want to follow on a couple of the words that Lloyd just used. Trust is a big one. As I've looked at the collaboration research over the past 30 years, while there's no quantitative way to weight the different factors that influence the success of collaboration, I would say there are two that stand out as being extremely important, transcending all forms of collaboration, not just healthcare and public health, but others. And those are, first of all, mutual understanding and trust among the participant organizations, and secondly, communication. And they are tied together. And for any collaboration to be effective, you're going to have to work on communication, and you're going to have to work on building trust. If it's not there initially, you're going to have to pace the work in a way that there can be trust. And actually, in one or two of the presentations this morning, I heard that element where people talked about starting slowly, getting to know one another in order to build up to the point where collaboration could be as intensive as they hoped that it would be. So mutual trust and understanding on the one hand, and communication on the other hand, extremely important elements. Well, we have two people. I'll start over here on the right side,
Okay.
which is our left.
Okay. Good afternoon. I'm Phyllis Meadows, and I'm a senior fellow with the Kresge Foundation. But in addition to having a long history working with philanthropy, I've also worked in public health as a health official for the city of Detroit. And I was really struck by your comments about foundations, and I just felt I had to take a foundation stance about collaboration, because I think your last comment sort of
I meant all
clarified.
foundations except Kresge, by the way.
Of course. I thought so. I just wanted to check.
Actually, I didn't at all mean all foundations. I just meant there have been some who have done it blindly, yeah.
Well, I just wanted to add a comment on that, because as a health practitioner, as a public health practitioner, and as a philanthropist, I can't imagine any problem that has been addressed effectively without some collaboration. And if you look closely enough, you will see those. I think your point, or a piece of your point, is there's a level of readiness, because as we talk about collaborations, people talk about them like they can just happen, when in fact there's a huge amount of skill and competency and readiness that must be in place to be effective in a collaboration. I mean, there's also some contextual realities that need to be in place, along with political will, the opportunity and the space and the resources to do collaboration. So I think they're an essential part of work, and the work that we're talking about today. But there's also some aspects that we just sort of assume that people can do this work. It's very hard work, and it takes a lot of skill to build effective collaborations. And we often think because we have the will that we have the skill, and that's not always the case.
Right, and the research strongly validates the point you just made, that a history of collaboration in the community will greatly influence the success of any new collaborative initiative. So as you put it, the social, the political, the other cultural elements, to the extent they're there, you'll be more or less ready to collaborate. And of course, if they're not there, you don't just lament and say, well, I can't change history. What you need to do is to create that new culture, learn slowly, maybe foster some cooperation, foster some collaboration over short-term kinds of goals, so that that history develops, and then you can accomplish exactly what you're saying, because we can't assume that where there's the will, there's the skill.
Let me just quickly call out that actually our foundations are practicing what they preach. So the De Beaumont Foundation, Kresge Foundation, Robert Johnson Foundation, Colorado Health Care Foundation Advisory Board actually have pulled resources to work with communities around the community's defined needs. It's called Build Health. And we had, 1,400 people on the webinar, and 321 applications. They all require public health, primary care, and a lead community organization. But so we are seeing, it's not, I guess that's macro. We're actually seeing folks aligned around what do the communities need and how do we pull resources and expertise to do that. So nicely done.
Okay. So we're going to have to end in about 6 or 7 minutes. So a quick comment or question or whatever here, and one here, and then I'm going to ask Lloyd what his one piece of advice would be as we leave the room, and I'm going to give one piece of advice, then we'll be done. But your comment, question, suggestion, complaint?
I'm Pamela Russo from the Robert
Yeah.
Wood Johnson Foundation. I'll be curious to find out afterwards if you think AF4Q was truly a collaborative or not. But what I was thinking about is more that we've fostered as a foundation a lot of things which we call community of practice. So they are around a common theme. They mix professions, but it's mostly about exchange and support and sort of building momentum towards something, and as I understand it. We're getting very interested now in collective impact as another way of thinking about what a coalition or collaboration can do. So I'm just curious how you view these different, and then, you know, from our own experience, multi-sector, where you're really talking about not people in the health frame, but people across a variety of agencies, as you mentioned. But that's harder. Multi-sector collaboration is just harder. And I would also love to, I mean, I'm powering another question on you. We all believe in collaboration. I mean, we've drunk the Kool-Aid, we've had the experience. But if you were, I don't know, at OMB, and somebody asked you to give you the financial bottom line, the return on investment for collaboration, would you be able to answer?
Well, you're asking for a 30-hour answer in about 30 seconds. But my quick response is I think we could point to some examples of where collaboration has been cost-effective or cost beneficial. I think you're absolutely right that multi-sector collaboration across disciplines that start farther apart than public health and primary care is much, much, much more difficult. I mean, it's really like teaching people a foreign language to bring the finance people in with the public health people and trying to train them in one another's vocabulary. But I think that, again, what we're seeing through case examples, we did a kind of a show and tell conference in Minnesota a year ago where we highlighted 20 examples. What we're seeing is extremely promising, that it's working, that the different sectors are coming together around affordable housing, around multi-service centers. They're blending nutrition with exercise, with housing, with access to primary care. And I think it's very hopeful. But I'd be happy to talk more about it because we go to Sani and then we'll close.
So this might be a longer-winded topic too. So the Institute of Clinical Systems Improvement has competitors sitting around the table. They're medical groups, hospitals, health plans sitting around the table to collaborate. So my question would be, I mean, certainly coming from a public health background, collaboration's kind of in my spirit, but there's also times where competition. So for example, several years ago, Paul and I were both on Minnesota Community Measurement. Our optimal diabetes score in Minnesota was 4% when we started publishing the data. And being transparent with where we were really spurred people on. There was collaboration going on, but there was some healthy competition going on. And our rate for optimal diabetes care, so that's 5 measures, is now 40%. So there was an element of collaboration that went on. But there was a healthy dose of competition that went on. We just released total cost of care measure across the whole state of Minnesota for primary care commercial. And the variation in that is huge. And I can tell you, people are looking around the table and saying, what are they doing to get their numbers down? But they also want to do it because they want to compete on value. So one of the things we're actually going to talk about at my board retreat in March is what's the framework for where we collaborate and where we compete or where we do both.
Okay. And I think, you know, one of the elements of the answer is that there's nothing wrong with competition. That's a good thing. They will want to continue to compete. There are common elements of the environment, social, economic, political, that are common challenges, and there it makes a lot of sense to collaborate. We do have to stop, so, you know, your 30 seconds or so, if you had to leave the audience with one important piece of advice, what would it be?
So I'm going to do what I usually don't do and offer unsolicited advice because you give me the opportunity.
Yeah.
But we are not where we were 3 years ago. The environment has changed. We have more partners coming in. It is time to shift how we work from trying to get things started to looking at who's missing from the table and invite other people in. And when I probably talked to one of this group and broad every day, and I don't think I've had a single phone call in months in which there wasn't something that the person calling going on in their home community that that person didn't know about. We knew about it because we've been collecting stories from the playbook. So my advice is please go out and check, even if you checked 6 months ago. Your hospital has new rules, you have new partners, other people are joining in. Invite people back to the table and be as persistent in those invitations as you were in getting started, because they'll help extend your work.
Okay. My piece of advice would be don't be too rational about all this. Collaboration is built on fundamental elements of trust and person-to-person communication. What we do in this formal, complex, modern 21st century is really no different than what cave people did 3,000 years ago in terms of deciding whether or not to collaborate with the other tribe or to compete and kill the other tribe. It's exactly the same thing. It depends on personal relationships. About 10 years ago, a collaborative involving several healthcare agencies that was in Hennepin County just asked me to come in once to help them out with something. And as they talked about what was the biggest factor in their particular success in something that they'd been trying and it was just not working, there was conflict and everything else. It started with 2 members of 2 different organizations running into each other at a coffee shop, talking over coffee in the morning, saying, hey, next Tuesday, could we invite so-and-so and so-and-so? And then suddenly this informal meeting outside the mainstream began. It patched up a whole lot of the differences. It built understanding and trust, and they would all point back to it as saying, that's the reason why we were successful. So remember that informal, kind of non-rational side as you proceed with this. Well, that's it. Thanks very much.